Quem somos? O que buscamos? A DIN1 apresenta o núcleo técnico operacional do maior centro de diagnóstico em genômica da América Latina. Somos especializados em exames genéticos de alta complexidade e medicina personalizada. Oferecemos o melhor da medicina diagnóstica para nossos pacientes e contamos com uma equipe de especialistas em genômica, biologia molecular e bioinformática. Temos à nossa disposição o que há de mais inovador para aumentar a efetividade do tratamento e qualidade de vida dos pacientes. Contamos com equipamentos de amplificação e sequenciamento de última geração e metodologia de análise avançada. O nosso compromisso é trazer um diagnóstico de precisão com excelência. Trabalhamos juntos para entregar sempre o melhor resultado, porque aqui cada paciente é único. Você é a nossa razão de existir.
Olá, pessoal. Boa noite. É um prazer poder contar com vocês nessa noite para que a gente possa discutir um pouquinho sobre um tema tão importante, né, e tão contextualizar esse momento de pandemia, né, como a farmacogenômica, sobretudo a farmacogenômica na psiquiatria. Nós vamos dar Hoje é o início de uma série de webinars que pretendemos fazer sobre esse tema e, obviamente, é impossível esgotar essa discussão ou aprofundar de forma que satisfaça todas as expectativas e vontades de conhecer melhor essa ferramenta em um único evento. Mas a gente tem certeza que vai ser um pontapé inicial muito positivo. A ideia é que a gente possa falar um pouquinho sobre a farmacogenômica, o que ela é, quais são os benefícios que ela pode trazer, quais são as diferenças que a gente pode observar entre um teste ou uma ferramenta farmacogenômica, quais são os impactos reais que a gente pode perceber nos locais, países que utilizam a tecnologia. Para isso, nós temos um exemplo do nosso convidado e parceiro da Coriell, Dr. Jeff, que vai, num outro momento, poder, inclusive, nos mostrar um caso muito real que eles fizeram nos Estados Unidos, seguiram uma população na cidade de Kentucky e tem resultados fantásticos, coisas como redução de hospitalização na ordem de 29%, queda de medicamentos, efeitos colaterais na ordem de 29%, né? Diminuição de gastos com medicamentos. Ou seja, nós estamos falando de uma ferramenta absolutamente real, palpável e passível de se traduzir para os pacientes. Vamos contextualizar um pouquinho sobre a psiquiatria e a farmacogenômica, obviamente, né, entrando um pouquinho na sequência também em algumas discussões. Para isso, nós vamos contar com duas pessoas. O Dr. Thiago Sato, que é colega médico e também colega do grupo Dasa, e que vai falar um pouquinho sobre a visão dele e do grupo, de como é que eles estão vendo essa caminhada da temática da discussão da medicina de precisão, seja no Brasil, na América Latina ou no mundo. Na sequência, nós vamos ouvir uma palestra técnica, científica, do Dr. Jeff Shaman. Ele nada mais é do que o diretor científico da Coriell Life Sciences, que é uma referência mundial nos estudos científicos quanto à farmacogenômica. É uma empresa que admiro demais. Tive a oportunidade de ler e discutir profundamente sobre esse tema com o Dr. Jeff. Uma empresa que nasceu do Coriell Institute, presente em mais de 60 países, com essa ferramenta que vocês vão conhecer aos poucos cada vez mais. inúmeras publicações científicas em revistas como Nature, Human Genomics. Ou seja, nós estamos falando de uma empresa com uma propriedade para falar sobre o tema farmacogenômica. Para isso, então, agora eu gostaria e passo a palavra para o Dr. Thiago Sato, que vai nos dar as boas-vindas, é o nosso anfitrião, e, na sequência, ele já pode convidar o Dr. Jeff para falar um pouquinho, então, para nos dar essa aula. Dr. Thiago.
Pessoal, muito boa noite a todos. É um prazer estar aqui essa noite com vocês. Eu quero contar um pouquinho do contexto em que a gente vem com esse exame. Bom, me apresentar primeiro, sou o Thiago Sato, sou médico aqui na Dasa, eu cuido de inovação, toda a inovação em termos de produto, em termos de exames. Então, meu principal papel é realmente aí essa busca por novas tecnologias. E contando um pouquinho da Dasa, a Dasa, eu não sei quantos de vocês conhecem de nome, é uma marca aí que na pandemia ganhou uma relevância muito grande, pela atuação que a gente teve está tendo no coronavírus, já foram quase 500 mil de testes realizados aí, contra a pandemia. E a Dasa surgiu como uma rede de laboratórios aqui no Brasil, são mais de 45 marcas. E qual que é o intuito? O intuito é que a gente consiga dar o melhor diagnóstico aí para a população, e também dar a melhor ferramenta para o médico poder exercer o seu trabalho. E recentemente, a Dasa começou um trabalho muito forte de montar o que a gente está chamando do ecossistema de saúde, em que não só a gente tem o laboratório, mas a gente também tem a atenção primária, os hospitais, e a gente vem expandindo também para a América Latina. Já são mais de 250 milhões de testes no ano, a gente serve aí quase 30 milhões de pessoas no Brasil inteiro, a gente tem uma atuação muito forte. Há 2 anos, 3 anos já, a gente lançou a nossa marca de genética, no fundo ali do Leandro, que vocês veem, é nosso núcleo técnico operacional de genética. Ele é o maior do mundo, a gente realmente pôs muita tecnologia aí, muito investimento, para realmente ter os melhores testes genéticos, os melhores prazos, a melhor qualidade, o melhor time científico. A gente realmente está investindo muito para conseguir entregar o melhor para o médico e para os pacientes. E qual que é o nosso objetivo com esse ecossistema? Na verdade, é um só, assim, quando a gente olha e analisa de uma forma geral. Porque o que a gente vem vendo como problema do sistema de saúde são os custos. Os custos só sobem, ano após ano tem a inflação de custos médicos aí que cada vez crescendo muito mais do que a inflação normal, tá ficando insustentável para plano de saúde, para o paciente pagar do bolso, o médico acaba que recebe menos, então o problema disso são os custos, E a forma como a gente enxerga de controlar esses custos é oferecendo soluções custo-efetivas, que elas passam a olhar para o ciclo completo do paciente, desde que a gente tenha a suspeita como médico de uma doença, passando pelo diagnóstico, usando a ferramenta mais precisa no melhor custo possível e entregando o melhor tratamento na hora certa. Então, nesse contexto, meu papel como quem busca inovação é exatamente focar em tecnologias que trazem custo-efetividade. E elas fazem isso olhando o paciente de um ponto de vista individual, com ferramentas genéticas, ferramentas que predizem risco, reduzem o número de cirurgias, reduzem imunoterapia desnecessária, quimioterapia desnecessárias. E agora, né, que é o contexto aí do nosso exame de farmacogenômica, a gente consegue dar o tratamento personalizado para o paciente, né, consegue identificar aquele medicamento que o paciente vai ter mais ou menos efeito colateral, porque ele se acumula mais ou menos no organismo, e inclusive a gente consegue saber quais funcionam menos, né, quais o metabolismo do paciente vai ser muito diferente. E eu quero colocar meu ponto de vista aqui, né, antes de passar para o Jeff, para o Leandro, sobre um pouco da ferramenta, né? Vocês vão ver, é uma ferramenta incrível, porque quando a pessoa faz esse exame, ela ganha um reporte para a vida inteira. Então, cada vez que sai um medicamento novo e passa pelo FDA, esse medicamento ele é testado, é feito a análise genética dele, a farmacogenômica. Então, o paciente vai ter esse laudo atualizável para o resto da vida dele. Né? Isso é incrível, um laudo que não é aquele laudo de 40 páginas em papel, né? Um laudo totalmente navegável, interativo. E acredito que vocês vão gostar muito. Né? A gente escolheu a dedo esse exame, né? Tem muita ciência por trás, tem muita seleção científica no que é incorporado no. Então, a gente faz isso realmente aí à luz da ciência e buscando entregar o melhor, num custo efetivo. É isso. Agora eu vou passar a palavra para o Jeff. Jeff?
Hi, good afternoon, everybody. I'm going to take that as my cue to start, even though my Portuguese isn't great. Let me pull up a couple of slides here to make it easier for us to share some of this information we're going to talk about today that Leandro and Thiago started with. Give me 1 second to pull this up. Hopefully you can see my screen now. Thiago, can you see my screen?
Yes, perfectly.
Wonderful. Well, thank you again for inviting me to have a chat with everybody here about pharmacogenomics and specifically about the tools that we can use to help improve the health of our patients. And we'll talk about that in terms of both pharmacogenomics, the other risk factors involved with medication safety management, but also the psychiatric and behavioral health medications that we know are in use. To get started, just to give you a bit of an understanding of what we're going to talk about today, Thiago and Leandro already talked about a little bit how we work together with Gene1, Dasa, and Coriell Life Sciences, but I want to give you a little bit more of a background of who I am and why I'm here talking to you today at all. And then let's talk about personalized medicine and medications and genetics and how that can all be used together to make sure that our patients are getting the best care that they can. One of the things that you probably have on your mind and one of the reasons that you're likely attending this talk is what are the questions that we need to ask ourselves when choosing a laboratory or a pharmacogenomic provider? And so we can go through a little bit of that checklist, but understanding the importance of everything from the research to the laboratory to what genetics are actually being looked at and how that's being reported out in a way that's useful. So you as the physician don't feel like you have to be a geneticist or a pharmacist. Right? What we're going to do is we're going to utilize all of this technology that we're talking about to empower you to make good decisions in the clinic. Things you're doing already, we're just going to add more to your toolkit. Right? We're not going to replace anything, but we're going to add more and make it even more powerful for you. And then if we've got time, we'll talk a little bit about the innovations in action and better health and lower costs, a case study that I can share with you. So a little bit about us. Coriell Life Sciences was founded in 2013, but this was started from a company or an institute called the Coriell Institute for Medical Research that's 67, almost 70 years old in Camden, New Jersey, right outside of Philadelphia. So I'm on the East Coast of the United States right now. About 13 years ago, we started a study called the Coriell Personalized Medicine Collaborative. And the goal of that study was to look a lot like the Framingham Heart Study. It was to be a longitudinal study understanding the best practices for providing information on genetics back to clinicians. That was on Mendelian and risk predilection type genetics, but also pharmacogenomics. It was the basis of that research study that formed the way we do things at Coriell Life Sciences now. And now our goal is really to partner with the healthcare community to deliver this power of genetic science through personalized medicine and to create paths to better health and the most efficient care in the world. Now, let's talk a little bit about personalized medicine and what that even means at this point in time. We can generalize it as the tailoring of medical treatments to the individual characteristics of each patient. And what's interesting about that is, as clinicians out there, you're probably saying, we already do this. And the answer is exactly. What we want to do, though, is increase that by using as much about that individual as we can. And now with the costs of genotyping coming down, we can add genetics as part of that toolkit. So the conversations we now have with our patient is really to maximize the outcomes of their health and minimize those issues that they fear the most. And that can be different from patient to patient. So to talk about genetics, I know we took genetics in school a long time ago, and for most people, they're not physicians and clinicians like you guys. So I always start with this slide here. Genetics is very simple, right? We inherit things from our parents. In this case, we've got a dad, a mom, and our kid here. And what are the things that we inherit? We've got things like hair color and texture, eye color, heart health, right? Cardiovascular strength. Breast cancer, so disease predilection, things like how tall we are. And then we'll talk a lot today about metabolism of medications. The benefit, though, to this kind of personalized medicine is really to help people make informed decisions about their healthcare. The more information we have, the better off these patients are. So if we can provide information on predispositions to diseases, so cardiomegaly or diagnostic, so metabolic diseases and cystic fibrosis. This also helps us reduce time for medical odysseys when we don't really know what's going on in a pediatric patient, let's say. We also have companion diagnostics in an oncology space, and pharmacogenomics, which has improved outcomes by targeting treatments and increasing efficacy of those medications and reducing side effects. So an example now around cancer, just briefly. It used to be that you would send a slide off to your local histologist and he would tell you that it was a lung cancer or non-small cell lung carcinoma. But now we know that non-small cell lung carcinomas are not a singular type of cancer. It has many subtypes, and you can't always see that morphologically, but molecularly we can. And it's that molecular difference between those cell types that allow us to pick the different types of medications that we're going to use for these patients. In a similar way, we can do this to the medications that we're all using in the clinic today. Now, this is both to increase efficacy and decrease side effects. So as an example, about 27% of the population cannot metabolize clopidogrel. Now, you've probably heard of Plavix, clopidogrel. It's an interesting medication in that the enzyme, CYP2C19, actually turns on the drug, it activates it. If that enzyme is not present or is working poorly, you don't get the active metabolite. So it would just like, instead of just taking a medication and having it work, it's just like eating candy. It's not doing anything. And we want to make sure that we can tell ahead of time that this is going to happen. So rather than waiting for some poor outcome like a secondary cardiovascular event, let's deal with it ahead of time. Other drugs where this happens, codeine has little effect on as much as 20% of the population. And even everyday drugs such as acetaminophen, right, paracetamol, can have widely varying effects. Now, this is both for prodrugs like Plavix, where the enzyme turns the medication on, and drugs that are excreted, so ADME, that are absorbed and distributed and metabolized and excreted through the system. Think back to your pharmacology classes when we talked about Michaelis-Menten type equations. But all of this scientific stuff impacts both the patient, the physician, the pharmacist, the system, and the country as a whole. We know from the research that's out there, and none of this is going to be a surprise to you, although the numbers are going to be different from the US versus Brazil, is that prescription drug spending is going up, right? Both the cost and the amount of drugs, right? As our populations get older, they're on more medications. And so those drugs, the number of drugs being used are going up. Adverse events account for nearly 700,000 emergency department visits and 100,000 hospitalizations a year. These are all things I'm bringing up because I believe that together we can reduce these numbers and these side effects. Medication errors occur in so many people, both inpatient and outpatient, and there are almost 300,000 deaths in the US attributed to medications every year. Now, this is my friend Linda. She's 73 years old, and she's on 9 prescription medications. That's about average for her age. She's got type 2 diabetes and has issues with hypercholesterolemia, arthritis, a family history of cardiac issues, and she's just not doing well. In addition to all of this, Linda's got other factors that impact how she's feeling and how her medications work in her body. Those include lifestyle factors like her morning glass of grapefruit juice, which impact some of her medications. She's got drug-drug interactions and things like phenoconversion happening where her drugs might not work as well as they should because they're banging into each other inside her body. And 2 of her meds are completely ineffective because of her genetics. So just briefly going back to why your DNA matters. If you take a pill, the normal course of action is we take that medicine, our body uses it, that drug goes to the place of action, hopefully acts in that spot, and then gets excreted. Imagine though, if that process of excretion is slowed down. What you have is an increased amount of the drug in the body. So now it's as if you were taking too much of it and could potentially see the side effects like overdosing. The alternative is that you take that medication and the excretion pathway is running even faster than it should. So you're excreting more rapidly. Now the medication's not hanging out in your body long enough to do its desired process. So you're going to see less efficacy. Sometimes that drug is toxic and not beneficial. Sometimes it's non-toxic, but no efficacy. And so all of this is things that we can look at ahead of time. And really what I want to point out through this whole talk is that the old way of doing trial and error prescribing is not helpful anymore when we have this type of extra information. And we'll talk about some of the psychiatric medications where that's really important. We can even brush upon it now. Imagine antidepressants that take 4, 6, or even 8 weeks in order for us to see the benefits of those medications. If we can tell ahead of time that amitriptyline is not going to work for our patient, let's not wait 4, 6, 8 weeks to revisit it and see that it hasn't worked. We can do this ahead of time. So all of these variables need to be considered when talking about medication risks. And right now we're putting a lot of emphasis on the genetics, right? The metabolism, the adverse events, the competitive inhibition when 2 drugs try to utilize the same excretion and ADME enzyme. But we also have other drug-drug interactions. And then we also have to consider contraindications, right? Drugs that we shouldn't take when we have, say, liver or kidney dysfunction. We also have patients that are pregnant or breastfeeding. We also have pediatric warnings and geriatric toxicity warnings. Anticholinergic burden is a big deal here, since it's the #1 cause of slip and falls in the elderly. If we can reduce that anticholinergic burden, we can reduce hip fractures and the side effects and sequelae that come downstream of those. Duplicative therapy warnings. Are you taking 2 medicines that are supposed to be doing the same thing? We have drug label warnings and side effects and all of these other things to consider. And so what I also want us to understand and think about during this whole talk is that DNA testing is important, but not sufficient. We need to consider these other factors when considering the health of our patients. The cost of getting this wrong really impacts what we've called MA3, medication adherence, medication appropriateness, and medication adverse reactions. And where we see this impacting our patients is in the number of visits, emergency room visits, hospitalizations, lab tests. If we're talking about employees, the number of days missed. If we're talking about young folks that are taking care of their parents or their grandparents, they also are dragged into this as well. And so we want to increase both the health and well-being, patient satisfaction, quality of life of our patients. And we do that by reducing the adverse events and the other issues that we've been talking about. Now in the US, our population health experts really like talking about the triple aim and quadruple aim. I'm not going to talk about it too much right now. Suffice it to say, as healthcare providers, I think you have a good understanding that in public health, we want to help lower the cost and improve outcomes, but it also has to be easy for the provider, right? If this is going to add a burden to the provider, nobody's going to use it. It's not worth even talking about. But it also has to help the system as a whole. And that's where we're going to talk about all of this. So as I segue into the next part, what I want us to understand is all of the information that's actually available to us to make these pharmacogenomic reports very easy for you to understand. What we have is a set of research scientists, PhDs, pharmacists, MDs, experts in the field that are researching this every day. And this is the team that I support, and they do phenomenal work. It's absolutely amazing the amount of data that they can glean from what's out there. And by taking all the information on a drug biomarker level, understanding the phenotypes, right? What happens to the patient, it's then when there's enough evidence, we can provide a clinical interpretation. That's when a drug gene, a drug biomarker pair enters the report. We don't want this information to just be informative. You don't have time to read just fun research information. Instead, it needs to be clinically relevant and medically actionable. That means that you can take all of this information that a bunch of scientists have looked at and physicians have approved and be able to utilize it right away. And that's a process that we have created internally that looks at drug labels around the world, that looks at pharmacogenomic guidelines from around the world, CPIC, the Dutch Pharmacogenomic Working Group, the FDA, these other groups that you've read about, peer-reviewed research publications, and we take all of that information and score it. And on the right-hand side of the screen here is the paper that came out of this. And it describes a process of ingesting all of this information that we can on a SNP by SNP, and that's the smallest measure in the genome that we can look at, a single nucleotide polymorphism, and how that's going to actually affect the patient. And you don't have to worry about those details, but we'll talk about the importance of why having a laboratory that can test that appropriately is really important for your ability to trust the data and the report that you're going to base your decisions off of. So to give you a little bit of that background, we have a gene. The gene is what we're using as a proxy to understand how that enzyme works. So I talked about clopidogrel. I talked about a gene called CYP2C19. It's a fancy name. It's an abbreviation to make it easier for scientists to look at. But what we know is clopidogrel utilizes that enzyme to turn on. These are things like acetylators and methylators and glycosylators, right, that we learned about in biochemistry those many, many years ago. But what's important is in that gene, imagine a meter stick, at each millimeter is a base pair. And some of those base pairs, those variants are important to the outcome of the patient. It might not be all of them. So right now, it's not worth looking at the entire genome and doing whole genome sequencing, not at all. We know enough about the genome that we can target the individual variants very specifically because we know the outcomes for our patient. By understanding that and attaching that to a patient phenotype and function, now we can tell that if a patient has a specific variant in a gene and is put on this drug, this is what the likely outcome is going to be. And this is very different than in oncology, where we're still learning a lot about multigenic processes of and potential, right? And we talk about that a lot in a prenatal screening. What is the chance, the statistics of this gene affecting the fetus, the child? In pharmacogenomics, it's much, much more clear that if you have this variant, this is going to be your outcome. And if we look at all of the drug labels that the US FDA, the Food and Drug Administration, has put out, over 20% of those, and that number has actually gone up, is in the psychiatric space. Oncology still takes up the big chunk of this pie here, infectious diseases, but psychiatry has what I would consider the most impact. Now, the exciting thing about this is most of our patients aren't taking just one drug. It's not just a psychiatric drug. They're also suffering from diabetes. They're also suffering from cardiovascular issue and high blood pressure and these comorbidities. And so polypharmacy in our patients should be addressed, but psychiatry is a great field to start looking at this in. So the drugs of interest include the antipsychotics, the anxiolytics, the benzodiazepines, the hypnotics, the selective serotonin reuptake inhibitors, anti-ADHD drugs, some of the new anti-dementia medications. We're starting to learn a lot more about the PGX, the pharmacogenomic impact there. But on the right-hand side is a long list. It's an eye chart, too small to look at, but of the drugs and their biomarkers that are on FDA-approved labels. But our ability and our opportunity to impact health is beyond that. And for 2C19, we're talking about 28 to 38% of the population we can actually impact because of those mutations. If you're a South Pacific Islander or of Asian descent, that number goes up to almost 50%. Factor 5, Leiden, factor 2, MTHFR, the increased risk of venous thrombosis. So this is important in some of our women of childbearing age and the risk of a thrombotic event. 2D6 is big in efficacy of antidepressants, and we see that in between 40 and even 73% of our patients. Another enzyme, which is 3A4, you see that in issue in atorvastatin and other drugs in about 18% of the population. And if you look over the course of what the laboratory is testing, almost everybody has at least one variant in them that is going to be impacting a medication. So the laboratory data absolutely matters. It matters what genes are reported. It matters what variants are covered. Remember, genes is my meter stick. Variants are the millimeter slots. Copy number determination is also something you want to consider when researching a laboratory, especially and very specifically for CYP2D6. Now, imagine that I see and I test a patient and CYP2D6 looks completely normal. That happens most of the time. That's what we want. But what a laboratory might be missing if they're not testing copy number is that that patient doesn't have only 2 normal versions. They have 3 normal versions of that gene. All of a sudden, we're adding a new variable into our laboratory testing requirements. If they have 3 normal, then there's an increased rate of metabolism through 2D6. And we already talked about 2D6 being very important for the medications being used in behavioral health. And so in that case, when you're investigating and picking a laboratory, make sure that they're testing what's called CNV, which is copy number variants. You also want to look at the haplotyping experience and the phenotype interpretations or determinations. So let's see how much time I've got here, at least another 5 minutes. So I'd love to take some of this time to give you a little bit of a glimpse of a case study. We've been working with a retirement system for almost 3 years now and have the data on several thousand, almost 10,000 members. I just want to give you the public health view of who these folks are. There's close to 40,000 retirees in this population now, and they range in age from 65 to 108. Or actually now it's 109. I haven't changed my slide. They're on a lot of medications. They have high blood pressure and heart disease. They look like your stereotypic geriatric patient. It was very interesting at the very beginning of this program. We saw that 83% of the patients were taking medications known to have genetic implications. This was before we even looked at their genetics. By just looking at the sheer volume of medications and the specific medications they were taking, we realized that this was a good population to look at. What we did was we ingested that data. We did the genotyping on these patients. And that data then goes into a decision support tool. Again, at the beginning of this talk, I told you that genetics is important, but it's not everything. So what Coriell Life Sciences and together with OneGene is looking at is this clinical decision support tool that brings in additional information and provides out a risk reporting engine. Now, it got a little blurry here, but each medication is scored across the different risk vectors: genetics, drug-drug interactions, anticholinergic burden, Beer's criteria and risk-related toxicities, contraindications, pregnancy and lactation warnings, all of these risks. So you have a quick snapshot of the medications that your patient is taking and how much risk there is. This gives you a really quick way to triage and pick which medications we're going to interact with first. And the next thing that this program, that's the application, GeneDose Live, allows you to do is audition alternative medications in the same therapeutic class. So in the United States, there are about 74 medications on the market for depression. And if amitriptyline was your first choice, these tricyclic antidepressants, what we would do is say, amitriptyline has this genetic risk. What else is available to me to choose for this patient? And the program, the application, lists those out in order of least risk to most risk and allows you to pick a new one that's going to have a change. In all of this, about 64% of the medication action plans actually resulted in a change to that patient's plan. And we did some work to understand the cost to the plan as well. Not surprisingly, the folks that did not have their genetics done and were not part of the program actually saw an increase over time of the cost to the plan. And there's a reduction in the cost to plan spending after 16 months of about 14%. This also turned out, where did that savings come from? There's a reduction in pharmacy spend, reduction in hospitalizations, in slip and falls. And it also helped that the prescribers had a conversation with the pharmacist that was leading this program. So by having this information all there in one spot in GeneDose Live, now the physicians were more confident in making changes to their patients. And of course, I'm in a lucky spot. I get phone calls from patients every once in a while saying, you know, this is great. I'm walking the dog again. I'm playing with my grandchildren, and it's a fantastic place to be. So just to kind of wrap things back up, as you incorporate these thoughts into your understanding of care, think about the laboratory, think about the information that you're going to get. The report you're going to get should be medically actionable, but you also should be able to answer a few questions. And is one of them, the most important is this information in this pharmacogenomic report going to help change a patient's therapy management? Is it going to improve the patient's outcome and their quality of life or productivity? Might it change family members and how they're managed as well? And will it lower healthcare costs in the long run? And honestly, I think as providers, you should be thinking about your own time. That's valuable as well. You want these reports like the one that you would get from OneGene. You want that to be easy to use. You don't want to have to feel like you have to be a geneticist, but you also want to know that we are all here to help you if you've got questions on the genetics. So my colleague, Tom Eckel at Coriell Life Sciences gave me this slide, and I really like it. If you were taking a medication that wasn't effective or even potentially harmful, wouldn't you want to know? And I think that it's easy for all of us to look at this and this happy family here and say that, of course we do. So I'll leave it there. Almost exactly 32 minutes, Thiago. I told you I could do it.
Great, thank you, Jeff. Thank you, it was great. Agora, Leandro, passar a palavra para você.
Palestra, uma brilhante explanação. Eu acho que o Jeff nos trouxe alguns conceitos fundamentais, e inclusive exemplos da vida real que eles tiveram de resultados terapêuticos. O que também a gente pôde observar ao longo dessa trajetória, dessa caminhada do nosso teste, em parceria com a Coriell. E realmente, o feedback dos pacientes e das famílias, não infrequentemente, eles acabam ligando e pedindo, gostariam de fazer exames, inclusive, para mais familiares. Nesse contexto, uma das coisas que chama a atenção é o alto nível de critério científico que a Coriell sempre leva em consideração quando ela coloca um reporte com os medicamentos, com as recomendações. Então, eu gostaria de perguntar, vamos perguntar para o Jeff, qual que é para ele falar um pouquinho para nós sobre o nível de critério científico que a Coriell tem como corte para fazer recomendações em nível de farmacogenômica. Jeff, could you tell us something about your high level of criteria, scientific criteria, to put some indications of medications in the report, or why you don't put some medications, some usual medication for specifically about psychiatrists?
Yeah, great question. So the Gene1 report has a very specific set of medications, and the way that those are chosen is by this risk reporting team of pharmacists and PhDs and MDs who review all of the literature to make sure that the information that's passed along is clinically relevant and medically useful, okay? The way that they do this is only when, so there's this scoring that comes about. As you can imagine, that there's a lot of information on biochemistry, right? Information out of a test tube. That's helpful. It's a good start. But what I want to know, and to be able to have enough evidence and trust to talk to a patient about it, is I want to see this in large populations. I want to know that in a lot of people, a high N, that if a person is on this drug with this mutation, that I see an outcome consistently. So it's that kind of information that we glean, that CYP2D6 always, when there's a STAR2 allele, impacts amitriptyline. And it always impacts it the same way. Then the information goes to our Pharmacogenomic Advisory Group, the PAG, the PAG. Now, this is a group of luminaries in the field. It was chaired by Issam Zaneh from the US FDA. Howard McLeod, a luminary in the pharmacogenomic space here, is also on that committee that looks at this. And they review all of the information that comes from the scientists to finally give it a thumbs up or thumbs down. And they think about it both from a clinical standpoint and also an ethical standpoint. We only want to give information to our physicians that they're going to be able to utilize. We have this, this term in the US, and I'm sure you understand it even if it's not the same term, alert fatigue, right? When we're on our computers all day and talking about our patients, and those alarms, best practice alerts, and those alerts keep coming up and telling us, oh, they're on aspirin. Of course they're on aspirin. Everybody's on aspirin, right? We don't need to worry about this. We want to make sure that these alerts are something that you can actually act on. And so there are some medications out there that have not yet met the threshold of evidence that we require for it to be inside the GENE-1, inside GeneNo's Live report. And so you will see those, okay? It might be that we know that some medications utilize a certain enzyme pathway. But if the data is not consistent, it tells me as a scientist that there's probably more than one gene involved, or there's some other genetics or some other piece of information that's impacting the outcome for this patient. And so I can't tell you that this drug and this gene are important enough to make a change in your clinic. What I want to do, what this report needs to do, is give you the confidence that if it says that this gene is present with this variant and you want to put them on amitriptyline or haloperidol, this is how you're going to change the dose or change the medication. I hope that helped. I think you're on mute, Leandro.
Sure. Uma outra situação, e pessoal, se alguém tiver alguma pergunta, por favor, pode fazer aqui no chat, a gente repassa para o Jeff as perguntas, a gente pode aproveitar aqui esse momento de um cientista-chefe que nós temos aqui, de uma empresa que simplesmente batizou, registrou vários genes da farmacogenômica que hoje são relevantes. Nós temos a primeira oportunidade de conversar com eles aí. Então, fiquem bem à vontade de fazer as perguntas para nós aqui. Uma outra coisa que eu gostaria que o Jeff comentasse é a questão sobre a relevância, o impacto que ele vê especificamente da farmacogenômica na psiquiatria. Porque uma gama enorme dos medicamentos psiquiátricos acaba passando por genes, principalmente do citocromo P450. O que não significa que você avalia um monte de genes e eles são realmente traduzíveis em uma ação. Jeff, talking again about the number of genes and polymorphisms that we can evaluate. In psychiatry, it seems that the CYP2 is a very important pathway for the psychiatric drugs. Could you tell us that? Another question is, it's important to evaluate a lot of genes, 50 genes, 100 genes. Your results, big results from Kentucky, are from a high number of genes analyzed?
No, in fact, they're from about 60 SNPs on about 43, 47 genes. So 60 SNPs is the important number there. And on that panel, and the one that Gene 1 looks at, are some genes that we don't glean information from yet. Okay, and that's important because right now what we know about are those CYP2 genes that you just talked about, because those are metabolism. There's some other genes that we look at on the panel that your laboratory uses that is part of the drug transport mechanism. So when you think about how medication works, yes, you got to be able to turn it on and off, but you also have to get it to the place in the body where it's active. And if you can't do that, then we've got to find another way around it. So yes, there are metabolism genes like the CYP genes, but there are drug transport genes. SLC1B1 is a huge one when we're talking about liver metabolism. You can't get some of the statins across the membrane if that gene is not right. So what I would say is, even if the metabolism is okay, if you can't get things across the membrane, it's not as good. So we feel very strongly that that 64 panel, I think it's 62, 60 is appropriate, and it's fairly future-proofed. What's nice is that genetics doesn't change in our patients over the course of their life, okay? This is going to stay the same. So if you test me, you test your patient now, you can use the information for the rest of their lives. So all of that research that scientific team does, if they're going to add another drug gene pair, that gene is probably already on that panel because we already picked it. We know the important pathways. And so a new drug that we haven't even invented yet, it is likely to go through some of these pathways.
Oh, nice. We have some questions, for example, from Dr. Suelen Tavares. Which genes you consider are the most important for the psychiatrists, which impact in the quality of life of the people and the results of treatment?
I would say the one gene, if you had made me pick one, it would be CYP2D6. And the reason is a lot of the antidepressants, anxiolytics, antipsychotics utilize that one pathway. We also see 2C9 and 2C19, imipramine. We're starting to learn a lot more about the drugs going through multigenic, multi-enzyme pathways. And so the CYP2C9, CYP2D6 pathway is obviously very, very important for a lot of these medications as well. The other thing I hope that people think about is that while I'm saying that about psychiatric drugs, and we're going to learn more about two other SNPs, two other genes. ABCB1 is one of them, okay? This is a multiple drug resistant gene. This is an MDR gene in the blood-brain barrier. And it turns out if that's normal, it's more difficult for the patient to be treated. because what's happening is that that's there to detoxify and keep the brain cleared from toxins, right? That's how we evolved all of these enzymes in the first place. So it turns out that certain medications that use that, you as a prescriber, if you find out that there's a mutation in that transporter, in that multiple drug resistant enzyme, you can actually get better results out of your patient. We also know that MTHFR, there's really, really good research on adjunct therapy with folates and L-desmethylfolate in patients that have medication refractive depression. And so I think that MTHFR is something that you're going to start reading a lot more about and that we test on the Gene 1 panel as well. So even those are for our antidepressants. Remember also that not all of our patients are just on antidepressants and antipsychotics and anxiolytics, that they do have polypharmacy. And if we manage their depression or if we manage their diabetes, it turns out that their blood pressure is better managed, that their cholesterol is better managed. So I like to think about the whole patient, but I do realize that this is a psychology-heavy audience. So I appreciate the question. Thank you.
Fazendo resumo, a resposta do Jeff foi de que se ele tivesse que escolher gene, seria o CYP2D6, né? A família do citocromo P450. Uma família que está envolvida, é uma família de supergenes que está envolvida numa grande parte do metabolismo dos medicamentos psiquiátricos, né? De forma que realmente a análise desses genes impacta. Também comentou sobre a questão dos resultados que eles obtiveram de mundo real, avaliando e seguindo os pacientes, o impacto e a satisfação e aqueles reportes. E esse impacto eles conseguiram fazer chegaram através de um painel de 60 variantes em 14 genes, né? Essa é um painel validado mundialmente, um painel do qual eles têm uma expertise muito grande. Também destacou o gene ABCD1, que é um gene envolvido na resistência de múltiplas drogas, que está conectado na barreira hematocefálica e que, basicamente, ele bloqueia a entrada de medicamentos no sistema nervoso central. No final, ele também considera a questão de que os pacientes, na verdade, muitas vezes eles são pacientes que tomam vários medicamentos, vários fármacos, e que no contexto geral, essa ferramenta, essa análise poligênica, ela acaba se traduzindo em um benefício muito maior da área da psiquiatria, mas que nesse momento aqui, como a gente está se focando na área da psiquiatria, esse é o foco, né, o momento. Eu vou também perguntar uma outra coisa que ele já comentou, que o Jeff já comentou, né? Já que ele enumera a questão do CYP2DC, o citocromo P450, como muito importante na psiquiatria, eu só quero que ele nos dê a sua importância, assim, qual a dimensão da importância do impacto da copy number, né? Na alteração do número de cópias de genes, especificamente do CYP2D6. Jeff, the last questions, we are going to the end, but you told us that for you, one of the most important genes to be evaluated in the PGX is cytochrome P450, okay? If we talk about the system, we have to talk about the copy number variation. How is important, if you could put in a scale, how is important the copy number variation in the analysis? And the copy number variation is just analyzed by a number, or you have to put in a program imagine, calculate the impact of this?
I think in the 1 minute or so that I've got left, I would say that I won't work with a laboratory that doesn't do copy number variants. It is that important to the equation, because the answer just on genetics, it could be misleading without the copy number. So the copy number should be considered in the algorithm or in the understanding of phenotype, such that we understand ultra rapid metabolizer or poor metabolizer, and very specifically. Without copy number, you can get that wrong. And there's a paper out there that my team published. If anybody's interested, I'm happy to share it, that shows the risk if copy number is missed, that you have a range of answers that are uninterpretable in the clinic. So the laboratory might say that a patient is a *1*1, but if you don't have the copy number, you're not getting all of the information. So when we talk about trial and error prescribing and not doing that anymore, and using pharmacogenomics when we're having trouble prescribing, or being proactive about choosing the right medication, or stopping a medication that has adverse events or isn't working and choosing the right one, 2D6, CYP, cytochrome P450, 2D6, and copy number are absolutely required.
Thank you. Eu vou encaminhar uma última pergunta aqui. Eu acho que depois nós podemos ir finalizando. O Jeff responde, depois eu vou passar a palavra para fazer o fechamento nosso colega, Dr. Thiago Sato, aqui. Já vou também antecipando o agradecimento e deixando o convite, porque nós vamos fazer mais discussões. O Jeff está convidado a fazer mais discussões na área da psiquiatria e também queremos caminhar com discussões internas, inclusive entre os psiquiatras, né? Na verdade, nós queremos fomentar e veicular a discussão científica, né, profunda sobre essa tecnologia disruptiva. My last question, a minha última pergunta para o Jeff é se ele vê hoje, se ele consegue enxergar a farmacogenômica como uma tecnologia simplesmente entregue com um reporte no papel, onde você olha e você vê sinais no papel. Aqui você tem uma cruz indicando que pode haver interação ou que você pode ter efeitos adversos. Ou seja, o quanto pode ser positivo um reporte estático. Jeff, the last question, and after, I would like to thank you first because after me and you, Thiago will close the webinar, and we really appreciate your lecture. It's very nice. You are invited for more discussions, scientific discussions. And the last question is, Jeff, do you see some validation nowadays in a paper, a report with some signals? Oh, see some notes about interaction, static report, or the pharmacogenomics is a dynamic report like your tool?
Yeah, so a static report is helpful in a snapshot in time, and it's only genetics. So it does have utility in the clinic, right? If you just have a static report with genetics on it. What I believe is more powerful, and what we've seen, is that our physicians like to understand the whole picture of the patient. Drug-drug interactions, lifestyle, what people are eating and drinking, right? We know that these foods and drugs interact in a poor way. And what we know is that over time, while genetics stays the same, almost nothing else about us humans stay the same. So over time, we want to be able to change and be flexible to understand the outcomes of the patient. So I think the bare minimum right now is the genetic piece. And if you have that in front of you, you've got to consider all of the information about that patient. If you use a clinical decision support tool to help guide through the genetics, through these other risk factors, through changing lives of our patients, whether they're pregnant or not pregnant, whether they're geriatric or younger, I think that what we see is that our physicians are now listening to genetics more because this is an entire application and program. It was very difficult in the United States to get pharmacogenomics past our physicians. It's too much for them to think about. I think that's true. We're all busy. You don't want to have to learn genetics. You don't want to also have to be a pharmacist. By having a clinical decision to support tool to help you through it, it takes that burden and that thought process off of you and gives you a chance to do what you do best, right? It's not going to stop you from thinking. It's going to supplement and add to it. And what's nice is that you can now try things on the computer rather than in your patient. If you want to see if amitriptyline is going to work in this patient, just type it in and it will come up and say no risk or high risk, or haloperidol, or oxycodone, or whatever drug you want to try. Now we're not experimenting on our patients, we're experimenting on a computer. And that gives us the confidence to then do it in our patients. So thank you very much for inviting me. I appreciate it. I hope this was helpful.
Thiago, passo a palavra para ti.
Thank you, Jeff. Thank you. It was enlightening to hear you. Agradeço realmente a todos agora, né, por estarem aqui, fazendo parte desse momento de inovação, em que realmente aí um teste pode mudar, sim, a vida de um paciente. Né? A gente está aqui para isso, né, para impactar positivamente a vida das pessoas, né? Por isso que a gente fez medicina. E espero aí que a gente esteja contribuindo realmente com esse teste farmacogenômica para a gente conseguir aí entregar uma saúde melhor, sendo custo efetivo. Boa noite a todos. Thank you, Jeff, once again. Obrigado, Leandro. Obrigado a presença de todos. Muito obrigado.
Bye.
Good night, everybody.